completely flat. The posterior complex is present, but it's a little delayed. This is what we call the toast brain. We learned it from this term from Daniela, and it also should raise suspicion that something may be bad. And we are going to explain why we may have difference from the anterior and the posterior aspect of the brain development. The parieto-occipital fissure as well, and the different patterns of appearance, the calcarine sulcus. So these three are very, very important and should be checked at the time of the second trimester scan. The sulci of convexity will appear later on, normally after 25 weeks. I like to say that by 26 weeks, the corona view of the brain needs to be like these four leaves clover log, and it's very like grosso modo a way to check. So we need to have one indentation in each aspect of the brain, and it really, really helps us regardless the name of the sulci. Remember that the parasagittal view of the brain, so the surface of the cortex need to be completely smooth up to 25 weeks, apart of the sylvian fissure, the calcarine, and the parieto-occipital. We call it physiological lyssencephaly. This is 17 weeks. We also can check for the normal lamination of the brain parenchyma. And here we are not going to speak about gray and white matter, because the neurons are going to the cortex during the pregnancy yet. But we need to check for the normal lamination. And whenever we have oversulcation in early pregnancy, it can be very abnormal, and Gustavo has spoken about that. And whether we have a smooth surface in later gestational ages, so we need to suspect on the opposite. But you will see that it's not always true, and sometimes even in cases of lyssencephaly, we will see irregularity in the cortical and the ventricular surface in early gestational ages, just to make our lives a little more complicated. So we have different abnormalities of migration. We have paraventricular heterotopia, lyssencephaly, subcortical heterotopia, and microlyssencephaly dysgeria, and cobblestone malformations, and they are secondary to different problems. So in paraventricular heterotopia, the neurons are not even connected to the radial glial cells, so they stop and they stay there in the ventricular zone. In this group, we have a disruption of this complex apparatus that we have spoken in the beginning. So all that structures may be abnormal, leading to different types of migration problems. And whenever we have gaps in the pia mater, so we will be facing cobblestone malformations, and these neurons will over-migrate the cortex. Regarding our lecture, so the lyssencephaly spectrum, we have agyria, absent gyri, pachygyria, broad gyri, subcortical band heterotopia, so lines of neurons in between the subventricular zone and the cortical zone. And we may have the combination of frontal pachygyria and posterior subcortical band heterotopia. It seems very easy and fine, but it's not. Why? Because in the fetus, different from the postnatal pattern, we don't really have these clear-cut shapes of the brain, especially not in early pregnancy. Thick cortex is a sentence that may be used and applied in postnatal MRI, but it cannot be sensitively applied in the prenatal imaging. So we are not going to use the cortical thickness in order to help us differentiate between types. So this, although this is the postnatal literature, the prenatal life is quite complicated. What helps us is that lyssencephaly is an exclusively genetic disease. So different from other abnormalities, like Rick have spoken before, and also Gustavo, we have genes and now more than 28 genes that have been previously published, and genetics will help us. So if the phenotype do not, but the genetics will do so. And I don't have time to discuss further the expanding imaging and clinical classification postnatal, okay? But they use several criteria that unfortunately we don't really use and we cannot use. We don't have myelin in the prenatal life. We cannot measure the cortical thickness in prenatal life. So these criteria are not very well applied in fetal life. We can see from complete agyria. So what is agyria? Completely smooth everywhere in a gestational age that is expected to have gyration. And we can have pachygyria, so very broad sulci. And also we can have gradients. So here the anterior aspect is more developed than the posterior aspect, as you can see. Very hard to translate into fetal life. Okay, so here we have this publication resumes very nice the genes and the function of these genes and the diseases that we expect in different genes related to lissencephaly. In the postnatal life, the genotype phenotype analysis defined in this very nice publication 21 groups with very robust phenotype genotype correlation. Okay, and we need to learn this because we can sometimes translate it into fetal life, but we need to understand that not every sparkling wine is champagne. So delayed sulcation, smooth cortex would not be lissencephaly always in the fetus. And we have many challenges in fetal phenotyping because we cannot check other things in the fetus. These phenotypes, like Ritsuko says, the ever-evolving brain. So they are evolving throughout pregnancy, and sometimes not even in late pregnancy we can define the classic phenotype of a specific abnormality. Genes may have variable penetrance, although in lissencephaly is less important. Most of the genes, they have a complete penetrance, and it really, really helped us. And also we need to remember that the phenotypes may be very, very non-specific. So whenever we have an agyric fetus, okay, here we have the abnormals, and here we have the normals for comparison. This is a publication from Edwin Perello from France. And it would be easier for us, maybe not at 20 weeks, but later on to know that something very, very, very bad is happening here. So let's see some cases using ultrasound. Again, 28 weeks, completely smooth, looks like 24 weeks. This is the control for comparison. So we know that something very, very bad is happening here. Can I tell if this is LIS1, this is DX, whatever? No. And then I will check for associated abnormalities, for the fetal sex as well. And we should do a broad evaluation in order to get into the gene. But what is important in fetal life is to suspect on the delayed sulcation and then check the fetus, because these diseases are very, very, very severe, and the prognosis is bad, and normally the survival is very, very low during infancy. So this is LIS1, 23 weeks. We see that the Sylvian fissure is abnormal. We see no parieto-occipital fissure, and again, don't be misled by the ventriculomegaly, which is myelin. Because myelin ventriculomegaly may flatten the parieto-occipital fissure. Indeed, it may, but we need to remember and then to check the other fissures. No calcarine, no parieto-occipital, a very, very flat 17 weeks Sylvian fissure. And here we see what we can call the H-shaped brain, which is postnatally very, very related to the LIS1 gene. Okay, so although we are speaking about an agyric brain, but we see irregularities in the periventricular area, and these are very, very nice pictures from my friend Michael Silok. Here we see also the lamination is completely abnormal. blurred. We don't see the regular pattern of the lamination, although we see the cortical layer here, which it appears, so we cannot measure it. It does not help. If we check this cortex in the microscope, it would be very, very thick, four-layered cortex, and very disorganized. And if we associate these findings with abnormal facial findings, so we will have the Miller-Dieker syndrome, which may appear on two mutations in the LIS1 gene or deletions in the chromosome 17. And here we have other cases to show you. This is a gene variant in the PAFA-H1B1 gene, which is the LIS1 gene. Here we don't see a very severe Sylvian Fisher. The fetus was referred by mild ventriculomegaly in the community 11. In our case, it was not severe, and the cerebellum was normal. And here by these axial views and by the midline view, we couldn't suspect an abnormality. But here we see a subtle abnormal sulcation, especially in the frontal area. The posterior area was more developed. See the Sylvian fissures that are abnormally developed. Again, Karina, you are completely crazy. It's so hard to tell. Yes, it is. Okay, and if I try to measure here the length of the sulci, like they do postnatally, it does not help us. Okay, but the anterior complex is a very good clue. You see that the parenchyma is very, very, very thick, so there is a lot of brain. And the cortical thickness, again, cannot help us. This is the MRI. In the MRI, we can see better the gradient, so the posterior aspect is worse than developed than the anterior aspect. And in this fetus, we saw white matter heterotopias in the pathology, white matter and subcortical nodular and laminar heterotopias that we are not able to see inside the parenchyma of these fetus many times. So it's very, very frustrating during fetal life, but this is what we have and we need to deal with that. Again, in postnatal life, we can really, really associate this is the H-shaped brain regarding to LIS1 and BCX and ARX and many, many other patterns, but we are not able to do it specifically prenatal. Sometimes we see these H-shaped brain, 24 weeks, associated to a very, very, very small brain, and this is microlissencephaly, variant in the Relin gene, and this is microlissencephaly Norman-Roberts syndrome with also specific facial findings. But if we check 3 types of lissencephaly here, we can tell that these are H-shaped brain around 24 weeks, and each of one of them is related to a completely different gene. This is, I think, the most H-shaped brain that I have ever seen, and this is not LIS1. This is ankyrin, which is not even a specific lissencephaly gene. So beware of specific postnatal patterns, and we need to remember that we need to compare, to do a broader genetic evaluation. Another disease that may appear with a gyra early in pregnancy is cobblestone, which was previously called LIS2, and we know that this is the Walker-Warburg and is the cobblestone malformation. But in these cases, the parenchyma, not cortex, will be thin, okay, and normally associated with a ventriculomegaly, abnormal brainstem, severe cerebellar hypoplasia, and abnormal echogenicity of the parenchyma, extracerebral layer, and other findings that we may do. I'll take a couple of minutes more, then we enter this gyra and we finish. But something interesting that I want to show you is the ARX. The ARX also postnatally very clear phenotype. X-linked lissencephaly with abnormal genitalia and callosal agenesis or severe dysgenesis. This is the motto of ARX. But the 2 cases of ARX that we have presented earlier in pregnancy with irregular ventricular walls. really looks like polymicrogyra in early pregnancy. Never I would say that this fetus has lissencephaly. Okay, but so there is much more that we need to learn about the fetal phenotype of these abnormalities, especially in the early second trimester. But we can suspect, and we did, that something is very wrong with this brain, because the shape of the brain is different from the expected at this gestational age. And this was a twin pregnancy that was selectively terminated, and it turned out to be an ARX gene. Another male fetus, callosogenesis, callosogenesis, very abnormal sulcation, abnormal genitalia. We thought and we suspect that it's ARX, but it turned to be trisomy 18. Okay, so remember, common things happen commonly. Again, our fetal phenotypes are so non-specific, and we need to remember that. Regarding this gyra, so this gyra, differently from the lissencephaly, because lissencephaly, we have specific gene, and we go to the microscope and we see the thick cortex, very disorganized. So it's a quite well-defined disease regarding the diagnosis. This gyra is the new kid on the block, like Richard said, regarding the malformations of cortical development, because it's everything that we cannot fit elsewhere. So the cortex may have variable thickness. The boundary between gray and white matter postnatally is smooth, and there is an abnormal gyra pattern with irregular depth and orientation of the cells. Very generic. Okay, so I like the second better. If you cannot fit it in any other definition, so it's probably this gyra, until we learn more about these abnormalities. And the main entity of this gyra is the tubulinopathy, the tubulinopathies, because it's an heterogeneous group of disease that present abnormalities in the whole brain. Because the microtubules, they are in everywhere in the brain. So if we have an abnormal microtubule, we will have brainstem, cerebellar, and supratentorial abnormalities in every aspect of the brain. And they may mimic lissencephaly very well, especially in the severe form. So there are many genes. There are the most severe phenotypes, and there are the milder phenotypes. The most severe phenotypes, they will present very smooth, but in tubulinopathies, different from the lissencephaly, we can find specific patterns in morphology that will suggest, okay, this is tuba, and you go and you check and you find. So we see a brain asymmetry. Check again for the anterior complex is very important. We will see irregularities in the interhemispheric fissure. We will see, and this is very early gestational age, 24 weeks, but we can see asymmetry in the shape of the anterior horns, asymmetry in the size of the hemisphere as well, and in the development of the cells. Corpus callosum will be affected in a more severe or less severe way, as well as the brainstem and the cerebellum. In TUB A1A, everything will be very severely abnormal. This is the genesis of corpus callosum, 24 weeks, no sylvian fissure at all. And here the head circumference may be a little small, but not microcephaly. Most fetuses with tubulinopathy and lissencephaly, they won't be microcephalic in pregnancy. They will only be microcephalic later on, so it will not help us. Again, abnormal shape of the anterior complex, irregular interhemispheric fissure, abnormal shape of the basal ganglia, and abnormal brainstem and cerebellum. So TUB A1A is more severe, as you see here. So it's very hard not to understand that something is happening, because the associations are very clear. And what we learned about tubulinopathies is that Differently from what we previously thought, that if the fetus has one MCD, it can only be one MCD. In tubulinopathies, everything happens together. And this is the case of tub A1A with abnormal basal ganglia, abnormal capsula interna, abnormal shape of the lateral ventricle, pachygyria, abnormal sylvian fissures, and you see here, abnormal shape of the lateral ventricle, abnormal hippocampal structures, places with completely normal appearing cortex, other places with thick irregular cortex, which would be lysencephalic, and places with heterotopic of all types, nodular and band heterotopias of all types, and also places with polymicrogyria. So in tubulinopathies, because the problem is very, very basic in the brain development, different types of malformations of cortical development can coexist in the same fetus. There are milder tubulinopathies like, and I think TEB-BV3 would be the best example for that. And then the findings may be milder, but that pattern that I showed you before, it would be very, very good for us to suspect on the presence of tubulinopathy. And this is our latest publication on the spectrum of the abnormalities in mild tubulinopathy. Remember the anterior complex, remember the irregular interhemispheric fissure. Even in accident use, it will help us. This is a 34-week fetus with an irregular interhemispheric fissure. Here the findings are very, very mild. Brainstem is also asymmetric. There is mild ventriculomegaly. But if you remember the features, check on the shape of the anterior complex. You will be able to suspect on these abnormalities, even in early pregnancy. To finish, although tubulinopathies are the main representative of this gyria may appear in other diseases as well, and this is a female fetus with L1CAM mutation. So we will find more and more axonal guidance disorders that will present again with the gyric pattern. So we see dislocation is very abnormal, but we cannot tell a name. So remember the diagnosis of this gyria. To finish, so how can we screen for lysencephaly and this gyria? We need to remember our oscillation reference map. We need to remember that many cases will have very, very thick parenchyma during fetal life. We are not going to measure the cortex, or very thin parenchyma if we want to compare to cobblestone cortex. The lamination will many times be blurred and abnormal to the gestational age. Check for the presence of asymmetric brain. Check for the anterior complex. The extraaxial space, when the volume is reduced, will be enlarged, differently from the cobblestone abnormalities. Check for the presence of associated brain anomalies, and the extra findings will then help us sometimes to refine the phenotype and then to do a phenotype-genotype correlation. So facial dysmorphism, Miller-Decker and Norman Robert, genital abnormalities in ARX, hands and feet in other cases of dysgyria, L1CAM from tubulinopathy. And remember that the head circumference will not be a very good marker. Thank you very much, and I'll be here for to answer the question. Thank you.
Thank you very much, Karina. Oh, it happened that my video cannot open. Thank you very much, Nina,
and now we are seeing you.
And thank you very much. And we would like to have the question and answer time right now. And we have Gustavo and Nina here. And also, we have the, especially, the Ravi Chawi is coming from Germany. Ravi, you can show up. And we have several questions from the audience, and I'll try to select some of them. And the first of all, which is better, the more specific measurement of the small head, BPD, HC, or transcerebral diameter? Is it the HC, right, Gustavo?
Gustavo,
Gustavo,
you're muted.
please unmute.
Yes, yes, you are correct. The head circumference is the most important one. But again, if you perform an examination of the brain, you need to measure also the BPD and also the TCD. And many times the TCD can give you a clue regarding the cause of the microcephaly, because it can be associated with pontocerebellar hypoplasia or cerebellar hypoplasia, making the disease worse.
Okay. And is it easy to pick minor cortical malformation in routine scans from India? How do you think, the Gustavo, Nina?
Sorry, I didn't hear well.
Okay, so is it easy to pick minor cortical malformation in routine scans?
No,
It's
no,
difficult.
it's not easy at all. Very, very, very hard. Again, if we do a very, very dedicated scan, so sometimes we have some clues, but that's why it's so important to check if we have an opportunity to check the fetus later on. And I know that there are many, many limitations also regarding the law in different countries and access to for exams. But here in Israel, we are fortunate to have the possibility to see many, many patients in the third trimester in order to have then a more significant clue or that something abnormal may happen. And it's quite a limited access when we are in very early pregnancy.
Gustavo.
Evidently, it depends on many factors: your equipment, how much time you have for the examination, what is your experience. So the issue is to be aware that when you see something that seems to you different or abnormal, to go for a more dedicated examination, to refer to the patient to a place of expertise. Okay, let's say you have a suspicion that facial dysmorphism or abnormal genitals, or the lateral ventricles are mild ventriculomegaly, but you think that everything is normal. The midline is not straight. You don't see the corpus callosum. There is a lot of small facts or things that need a more detailed examination. But if you need to perform the examination in 3 or 4 minutes because there are 100 patients waiting for you outside, the chances will be quite low.
Yeah, actually, I think the usually routine scan is meaning the transabdominal
Yes,
scan.
yes. When you perform a transabdominal, I always recommend to go to perhaps what is the best, the most useful paper regarding diagnosis of cortical malformations. It's a paper, two papers that were published in 2004 by the group in Toronto, and Stoys and Fong. And by adding 3 seconds observation of the Sylvian fissure and the parieto-occipital fissure, to see the diamond shape of the parieto-occipital and the shape of the Sylvian fissure, you will be able to make a diagnosis. But again, it's important to remember that all these fetuses in their paper have mild ventriculomegaly. So there was something else. But look at the parieto-occipital in the axial plane, transabdominal, and if something seems to you wrong there, again, go for a more detailed examination or refer the patient to a center of experts.
And it's Ritsuko,
Ravi,
I want to add something just, and I will link to Rabi because I'm very happy that Rabi is here. That something that I really like in his lectures, and I will address. Anterior complex. This is the catch. Again, together with the Sylvian fissure and the pareto-occipital fissure, which are very important. I think this is the simplest thing and the penicillin of the fetal neurosonography, because it is a game changer. It will help us if you check on the shape of the anterior horns, the regularity of the interhemispheric fissure, and the periventricular area around the anterior horns. You will be able to raise your detection rate a lot regarding heterotopias, regarding brain damage, regarding milder malformations of cortical development. So I think if we can say something very easy in axial plane that is a game changer, adding the anterior complex to the Sylvian fissure axis in these fetuses. And the link with Rabi. Rabi has amazing lectures on this morphology and on the face, and more and more, I think in the last year, many diseases that we have suspected only because of the philtrum and the nose and something different in the eyes or the ear. So the importance in specific groups of MCDs to add the facial dysmorphology, especially later in pregnancy, because it becomes clearer in order to suspect on abnormality. Thank you, Ravi, for being here.
Yeah, thank you. Yeah. Hi, good to see you again, my friend. So actually, I was supposed to be in the background, but Prashant wanted me to jump in. So I'm sorry, I'm not shaved. And it's Sunday, I'm sitting at home. And anyway, so let's see what I learned today are several things. One of these is what we are doing. We are doing a basic scan on a BPT as usual. And we learned now, of course, to implement the cortical, let's say the Sylvian fissure, to look at more carefully too. But I learned today also it's important to implement also the anterior complex to see any asymmetry and to compare the anterior part of the brain to the posterior part of the brain. So if you have any ventricle size of some 7 to 8 millimeters, it's not the one, 12 millimeters are already abnormal, but 7 to 8 millimeters, look at the anterior part. Do you have anything additional? Is there a need then to switch to go transvaginal? And if you are scanning transvaginal, as Srixoko is suggesting, you have an excellent possibility to compare two hemispheres. If you are scanning abdominally, the proximal one is hiding. So this is why to the question asked, is it easy? If you don't have additional hint, no. But if you're looking to if you add to your checklist the Sylvian fissure, the shape of the CSP and the asymmetry of the brain, the anterior to posterior comparison, then you may discover these things. This is my comment. And for you, Nina, you give me now an idea for a new talk. We could call it one day, the face predicts the brain, not only on holoprosencephaly.
Thank you very much, Ravi. Okay, so let's move on. The next question. Should we measure the corpus callosum routinely?
Can I add something?
Yeah.
I think if at all you are evaluating anterior complex, it's a one good volume will add a lot of information to your CNS. If you have got one good volume imaging of anterior complex, it will add on a lot of information. So I feel, what is your comment on this 3D for utilize anterior complex evaluation? Ravi, your comments, and Ruchiko, your comments also.
Ravi?
Yeah, so I learned from Mitsuko, if I'm scanning transvaginally today, tomorrow, I'm always acquiring volumes, because especially if you want to compare left-right, you may be very oblique if you are looking to 2D. Because, if you think one hemisphere is larger than the other, and so if you have a standardized approach, you don't need to scan longer. You can have several volumes. Later on, you can have a look here and there. And this is what I changed today in my daily work.
actually, that I do always taking the 3D volume for any kinds of brain, normal or abnormal. So, but that I learned from the cases that the very subtle abnormality can be detected by the 3D. That after the rotation and the looking at the the tomographic ultrasound imaging. So I think of course I do 2D scan, and then I look at I took the volume later on. So that is much more helpful for the offline analysis. Is that okay, Prashant?
So that's it, but especially with early brain, when you try to evaluate from 14 week to 24 week, I think ultrasound and 3D ultrasound is probably better than MRI, if I'm not wrong.
Yeah, of course. In early pregnancy, before 18, before 16 weeks of gestation, there is much better. The 3D ultrasound, or even the 2D ultrasound is much better than taking MRI. The MRI, it is quite difficult, to take 16, 14 weeks baby, right?
Yeah.
Okay, shall we? Okay.
Can I make
Ravi?
an observation? Two
Rina wants
observations.
to add something.
If you just very careful with 3D volumes, because if the patient breathes in the middle, sometimes you have a very tiny irregularity, and
Yes,
then
yes.
you think you have heterotopia, whatever we can call it that. So check also in the cortex, then outside and everywhere else, then you can have this movement because it's tricky and
Yeah,
sometimes it's a problem. And also I think for the lamination analysis, sometimes the quality of the acquired volume may be questionable. So
Claro.
always, if you suspect an abnormality of the lamination in the volume, go to the 2D and compare. We have done it with our latest Voluson, and we see very interesting findings. So whenever you suspect on a volume, I think for the lamination, check with the 2D scan.
yeah. Okay,
I
Ravi?
I have a question for Gustavo because when you were saying the size matters, I wanted always to ask you this question about macrocephaly. When you see macrocephaly, what is the role of the subarachnoid space? Because you may have large BPD or large head circumference, but the brain size is normal, and sometimes you have some enlarged subarachnoid space, which is could be rather the kind of where the father has this, or sometimes if it's let's say symmetric as usual, and the brain is also big. So do you know, or do you have experience, or let's say more empiric experience, if this plays a role to say the macrocephaly with large subarachnoid is for me rather normal, but if it has its own symmetric normal, it means the brain is large, so macroencephaly. Is there any data to this?
Yeah, for years the neurosurgeons were speaking about they call arrested hydrocephalus, or they have a lot of names for these cases. Even they used to perform surgeries that today is quite clear that is not necessary. So you have a child or a fetus that have a very large head. The head circumference is very large, okay, and there is a lot of fluid around, okay. Usually it will be okay. The problem is when you have a head that is small or normal and a lot of fluid around, and this means that you have microencephaly. So the problem is more common there, that you see normal head circumference but small with a lot of fluid around. Those are the cases that I am truly worried. Uh, but again, when we speak about macrocephaly as a synonymous of megalencephaly, we accept that we are not speaking about fetuses that have hydrocephalus, ventriculomegaly, or very large subarachnoid spaces. Uh, the other problem with subarachnoid spaces is come when you perform MRI, because when you perform MRI and there is a lot of fluid around the brain, the radiologist needs to be aware of that, and that the fact that the dysuchia are more pronounced. We have a lot of discussion regarding this fact. So another important thing is that we measure, we published years ago in 2001 a paper where we measured the size of the subarachnoid space, and if you measure it in a coronal plane at the level of the foramen of Monroe, it should be not bigger than 5 millimeters.
I know. I cited your paper. Unfortunately, you cannot come to FMF.
No,
You
I still,
measured
you know,
the sinocortical and the craniocortical. But today
exactly.
we see the perisylvian, and there are no measurements done because, you know, if you go vaginally, you don't have a clear part to measure. For abdominal, there are some paper measures. So, but yeah, I want to more to know more your empiric feeling. So, does it play a role, or you look at it when you have macro? So, thank you.
Thank you. Shall we go move to the next question?
Come to next lecture.
Honey?
We're in time.
I'm not sure.
Actually, we are running little late. We are running little late, so we will cut short those question and answers. So I think if it all,
Okay,
it should
so
be presented first, and then, if possible, or you may keep, you may have some 2 or 3 or 4 good questions. You select, and then we can go.
okay, so actually, you know, some of the participants, they don't know, they don't understand the shape 8-shaped brain. So would you
Okay.
please explain about?
Can I share? Can I share it again?
Yeah,
Yes.
if possible, you know, yeah. So
Yes. So I will
what
share it again.
what is 8?
Okay. Yes. Okay. This is good. In fact, I had the number 8 printed on, and I have erased it. Now I understood that didactically it was wrong.
Yeah,
So
many of the
It's,
the participants,
actually,
It
it's
they
should
don't.
say figure 5.
toast shape brain. This is Daniela's.
yes.
Yeah. Okay. This is 8.
Do you? Yeah. Do you see?
Yes.
Do you see the slide? Okay. So normally I will do something else. I will go back to Ritsuko's here. So you see, guys, that even after 21 weeks in coronal view, but especially after 23 to 24. So we need to have a sharp angle, 90 degrees. So we have the frontal lobes, and then we have the Sylvian fissure quite marked in a square shape indentation here. Whenever we have 17, 18 weeks, so we
Sorry,
have the round shape. So this would be like the 8-shaped brain. Okay, like
round.
a round and round. And here we shall have normally this marked separation, and after 23 it should have a 90 degrees angle. So, and here we have what we have called the toast. So the toast, like the upper portion is smooth and does not make the round, and the lower portion is developed. So here I will show you again in postnatal literature. So this is list 1. So we have like the H shape. This is the classic shape of list 1 in postnatal literature. And what happens in the fetal life is that, let's check where I am again here, that we can have different diseases that will have quite a like pattern. And the one that I saw that it's the most H-shaped brain, and I was sure that this fetus was list 1. It was not even a classic lysocephalic gene, but this is list 1, and this is the shape that they tell. So what is important is the shape of the Sylvian fissure that is quite delayed, abnormal, aberrant in these fetuses. Hope it has
Okay.
explained.
Yeah, most probably, you know, that they can understand. Thank you very much. And Gustavo, do you explain about the polymicrogyria, which is very obvious, in the brain, by neurosonography or neuroimaging, but sometimes, it is very, very difficult to see the histologic polymicrogyria. And you explained about that, the very shortly. So would you please, explain more about the difference between the histological polymicrogyria and neuroimaging polymicrogyria?
Okay. From the histological point of view, polymicrogyria is the presence of abnormal many small gyri that are not covered by meninges. Okay, they look they look like a gyrus, but the normal gyrus are covered by meninges. The sulci, inside the sulci, they need to be covered by meninges. From the pathological point of view, polymicrogyria means sulci that they look like sulci, but they don't have meninges inside. From the imaging point of view, we call polymicrogyria everything that is different. When you see difference in the shape of the sulci and gyre, you have more than usual, smaller than usual, but this is quite clear when there is a severe form, usually with associated malformation. But when you have normal lateral ventricles at 37 weeks or 35 weeks, the chances to make a diagnosis of polymicrogyria is difficult. And we have shown that it's also difficult by MR. We have a very, very sad case where at 27 weeks, the MR was considered normal, and the child was born with very severe polymicrogyria. So we are not good there. We are not enough good there. And when it's vocal, we are even worse. So I don't pretend, and you must understand that the polymicrogyria is tricky. And again, I think that eventually, as I finish my lecture, if you want to have a good diagnosis, start by doing exomic sequencing, and then you are going to find many, many diseases that are not present during fetal life or even during the first years of life. We are far away to reach 100% diagnosis of brain disease by ultrasound. If someone pretends that he is able to see everything, he is cheating or wrong.
Okay, thank you very much. And we have more questions from the audience. However, we are running out of time. So can we go for the case conference question? Question is okay. So thank you very much for discussion. After 3 cases from the Asian ladies, maybe we can have the Q&A again. Okay, so please be staying here. Okay, so next are the 3 presentations from Asian ladies, and the first is the Dr. Nguyen. She is from Vietnam and currently serves as the director of the Fetal Medicine Center at Pan Am Junior Hospital in Ho Chi Minh City, and she has a long-time experience of the fetal ultrasound in Vietnam. And the second one is Dr. Isabella Ward. She serves as the consultant and honorary associate professor at Prince Wales Hospital, Chinese University of Hong Kong, working for the brain clinic with Professor Leona Poon. And the third one is the Dr. Virada Deliafat from Thailand, the OBGYN department, maternal fetal medicine division of the Ramatibodi Hospital, Mahidol University, Bangkok. And she studied neurosonography in my institute, Osaka, Japan. So 3 of them are discussing about their rare cases. So from the first one, please. After 3 presentations, we will have the Q&A. Okay. Thank you.
This is a 35 years old lady in her first pregnancy. For first trimester combined Down screening was low risk, with a normal nuchal translucency, and the non-invasive prenatal testing was low risk and showing a female fetus. Ultrasound at 18 weeks already showed there is evidence of hydrocephalus, and this patient was referred to us at 20 weeks of gestation. This is the axial view showing bilateral severe hydrocephalus, and the transcerebellar view showed the transverse cerebellar diameter correspond to 18 weeks of gestation. Fetal morphology in other systems were all normal. In particular, there was no active form, and this is a female fetus. This is the axial plane of the fetal brain. Besides the severe dilatation of bilateral lateral ventricle, the parenchyma was thinned, and the third ventricle was dilated, but the fourth ventricle remains normal. And on the sagittal plane, the midline structure could not be clearly seen, for we captured a 3D volume of the fetal head, so allow us to have a better appreciation of the midline structure. After capturing the volume, by stretching the brain by manipulating plane A, then I draw a line in the middle, so the reconstructed sagittal plane could be shown precisely. Then I slowly move the line to the side, so you can clearly appreciate the thinning of the parenchyma on both sides of the brain. So when I go back to the mid-cellular plane, there is a thin corpus callosum and a dilated third ventricle. Then I capture another 3D volume in the sagittal plane. Then I swing the line from here, so can allow me to appreciate the coronal plane from the front and to the back. The inner hemispheric fissure is intact, but then here you can see that the cavum septum pellucidum was ruptured, and there is dilated foramen of Remoulin. We routinely measured bilateral circumfissure angle in the clinic, and there was obvious delay in the development of bilateral circumfissure. And this is the MRR of the fetal brain in the coronal plane from the front and to the back. And this is the sagittal plane. So this is the mid-cell section of the fetal brain. I think some of the experts here may already know the diagnosis after showing the MRI. So here you can see there is a brainstem kinking as compared to the normal reference. So to summarize the finding of this case, there is presence of severe hydrocephalus and a small transverse cerebellar diameter, and also a delayed circumfissure development. And last but not least, there is kinking of brainstems. So amniocentesis was performed and a chromosomal microarray showing a negative results. Therefore, we proceed with the whole genome. Then we proceed with the WGS, showing the fetus is having a compound heterozygous pathogenic variance in the POMGNT1 gene, which is associated with muscular dystrophy dystrophy. With a prenatal onset, it is associated with a more severe presentation, and it is also known as a Walker-Warburg syndrome. This case had terminal pregnancy performed, and thanks to our pathologists. For the brain dissection, size A marked hydrocephalus. In the histology slide, there is evidence of polymicrogyria, which is characterized by the undulating descent of the cortical layers, as indicated by the circle on the right-hand side. So the lesson to learn from this case is that in the case of severe hydrocephalus, besides looking at the hands and gender to exclude L1-CAM syndrome, we also have to pay attention to the brainstem, which could guide you to the diagnosis. Thank you for your attention.
Good evening. Firstly, I'd like to thank the Fetal Society for giving me the opportunities to present our malformations of cortical development or MCD case. It's my honor and great pleasure. A 33 years old, 23 weeks and 3 day pregnant woman was referred to our hospital in January 2023 for suspect enlargement of the left ventricle's anterior horn. Ultrasound exam at 10, 14, and 19 weeks revealed no major anomalies, and the NIPT showed a male fetus with a low risk for common aneuploidies. Her last child, who is healthy, was born 2 years prior. The left image in the anterior coronal plane shows asymmetry. The left anterior horn is enlarged, square-shaped, and has an irregular lateral wall. Past the serial features are also asymmetrical, with the left side appearing shallower. The curve on the right scans from the anterior to posterior. Here show an enlarged left lateral ventricle. You can see several scattered nodules along the frontal horns and body of the ventricles protrude inward. In these parasectital views, you can see both sides of lateral ventricles. The right lateral wall is smooth, while the left side is enlarged, bumpy with increased echogenicity, suggesting periventricular nodular heterotropy (PNH). We requested a fetal Benny MRI to confirm the diagnosis. Picture 1 and 2 show axial views, and picture 3 show the coronal view. The left lateral ventricle has an irregular margins with small nodules along the wall, marked by the red arrows. This view also shows the symmetry in the cortical surface. The right is smooth, but the left, shown by the blue arrows, is irregular. Picture 3 reveals the left ventricle is enlarged, with a small nodule protruding into the lumen. The green arrows point to the serial features, which is shallower on the left. As a result, unilateral PNH with abnormal left cortical surface is suspected. Our diagnosis is PNH with an abnormal left cortical surface at 23 weeks and 3 days. Let me briefly summarize the key findings on this slide. Enlarged square shape, irregular lateral wall, nodule protrude inward, irregular cortical surface, and shallower left serial feature. So what did we do? We talk about the fetal brain finding to predict the postnatal outcome. Key factors include severities, fetal gender, and genetics. The main worry is that 70 to 80% of cases will develop epilepsy, which can start anytime from birth to adulthood. Most will have severe drug-resistant epilepsy, needing targeted treatments. Since PNH are deep in the brain, surgery is risky. For example, removing a nodule in the occipital horn could affect vision. The severities also depends on the baby genders and genetic test results. PNH is often caused by a defect in the vitamin A or FLNA gene, inherited in an X-linked dominant way. Since this case is male, it usually indicates a more severe condition. We also discussed about her genetic testing and the chance of recurrence in future pregnancies. In Thailand, abortion is allowed up to 24 weeks. So after consulting with specialists, the parents decided to terminate the pregnancy and do further genetic testing, including exome sequencing. Here's a gross examination of the fetal brain after termination. Picture 1 and 2, you can see the difference in the cerebral surface. The left side is more mature than expectation for the gestational age, and here an irregular cortical surface in the pericinium area, while the right side is covered by subdural hemorrhage and shows some sign and giant formation. Picture 3 shows a coronal section of the frontal lobes with nodules, these pink arrows, along the left lateral ventricles. A microscopic examination was done to check the abnormal finding from gross examination. The upper image shows many normal baby neurons remaining in the ventricular zone and forming nodules along the ventricular surface. Here, instead of migrating up to the cortical plate, as they normally would. The lower image shows area with extra small folds called polymicrogyria or PMG. Genetic tests, karyotype and SNP array from cord blood show a normal male fetus. Exome sequencing found an FLNA gene variant inherited from his mother, but it's benign or likely benign variant, so it doesn't explain the patient condition. Here are some key points from this case. The enlargement is in the anterior horn of the lateral ventricles, not the posterior horn, which could be missed on a standard OB scan. Number 2, this is a condition with PNH and PMG, which might lead to more severe issues. Number 3, FLNA variant found is benign, so it doesn't explain the brain anomaly. For her next pregnancy, the recurrence risk is unclear. If she tries again, we advise early, detailed ultrasound monitoring. Lastly, I'd like to thank the OBGYN department for all their support. Special thanks to Dr. Chayada, the primary physician, Dr. Patama for beautiful OB scan images. And I'm also grateful to Professor Poo for inspiring and guiding me into this field. That brings me to the end of my presentation. Thank you for your attention.
Thank you, guys. The excellent presentations from 3 countries. I also feel that everybody is doing very passion with passion and personality and very beautiful. So now the discussion. Could you please show up, 3 of you, and Isabella and Miranda. And is there any questions from the faculty?
Yes. Okay. Let's start asking for the case with the 2PV3.
The first one.
Perform an MRI on the parents or trio exomics.
Sorry, we recommend, however, the parent refused. Yeah, with their first baby.
The exome, you didn't do a trio, you did only the exome with fetus.
Yes. Okay, so it's not the trio. It's solo.
So you need to be aware when you give a genetic consultation that the chances that 2BV3 is from one of the parents are quite high. So, and in these cases, the prognosis can be good. So you need to ask for a very good neurological examination of the parents. Once you perform an MRI of the parents, brain MRI of the parents, or to do an exome of the parents, because if one of the parents is a carrier, or is affected. It's not a carrier, it's affected because it's autosomal dominant disease. The chances that next pregnancies will come with the same findings are 50%. And this is very important, and I am speaking based on my experience that we have two cases where in the past we terminated pregnancies because of similar findings, and it turned out that the mother, in one case the mother, in the other case the father, have the same disease, and in the third pregnancy with the same findings was conducted, and the child is born and is completely normal. They may have some learning problems or things like that. This is regarding the first case. Regarding the second case, the third case, the periventricular nodal heterotopia, we have learned in the time that many cases we used to classify or heterotopia or PMC, but as different disease. But we have found that many of our cases that are very severe have both, and this is a transparenchymal involvement. And in these cases, you don't expect to have a filamin disorder, but what is expected to have is a very serious condition. So it is well that you recommend termination. And in the question would be, did you, in the case of the walking-like syndrome, did you examine the eyes? Because usually in these cases the eyes are also pathological. You will find or retinal detachment or some kind of muscular findings are not usually in this case you will have also something in the eyes, and thought it's very you say okay it's walking marble, but also it can be Hubert, so you should be careful there. Those are my
Thank you very much for your comments. And Yuan, maybe you will have a chance to take MRI of the parents, and also take their blood for the trio exome sequencing, right?
Yes, we learned from Malaysia study, and we know that to decrease with prognosis and yes from the parent. So we asked them, however, they difficult for them to have the MRI and exome sequence. And anyway, they would like to continue pregnancy, so they refuse to do and follow up, and we let you know the outcome. Thank you.
Okay, so because that is a very mild case, right? Okay, so the second case, Isabella, did you examine the eyes?
Well, we did a scan, so we routinely see the eyes, but then I cannot pick up any abnormality on the eyes. And then our pathologist didn't do a dissection on the eyes as well. Yeah, so I'm not sure.
You did the autopsy, right?
Yeah, but then we didn't cut the eyes.
Okay, so all right. So, but the findings of the eyes is one of the points in the case. And the third case, Virada. So, you showed us the very big heterotopia, right? So there is the one of the audience asked that is that the heterotopia or hemorrhage? Do you think that that is a heterotopia?
We think on the left lateral ventricle that is the heterotopia. Yes, and we confirm by the gross examination and microscopic examination. And as you see, the hemorrhage is on the right side. It's opposite, another way.
But the zone that you show as heterotopia, I think that actually you are showing the embryonic eminence that is very rich in neurons, and this is the so the heterotopias should not be there, should be more laterally in the lateral ventricle. But what you show very nicely is the polymicrogyria. But pathological polycythemia is nice. But this very blue zone is the gangrenic eminence.
Oh, but what do you think, Virada? Is that the place for the gangrenic eminence, or do you think is that the outside lateral ventricle, right, or inside? I think the gangrenic eminence is below the lateral ventricle. So if it is a gangrenic eminence, maybe the place you took the tissue. Because you are so big, right? It was so big, and usually, the heterotopia, the lateral, the heterotopia is like this, right? So, Ravi, do you have any questions?
No, my tip to Virada, have you heard the session from this morning? You were there?
Yes,
So
right.
what you should do actually in such a case, if I was you, because you don't have an explanation, ask the geneticist to perform exome on this part of the brain. Because we heard today that you may have mosaicism. If you have asymmetry, it's not tubulinopathy. You have one brain looked like the other one different. And this is, I think, the next part where we may find mosaicism in some part of the brain. Explaining this, why not? Could be.
Yeah.
Yes, Professor, indeed, we did the brain, the tissue biopsy to rule out the somatic mutation as well. And the reason is only the FLNA1 benign variants also.
Wow.
You did that. You did that.
Yes, yes.
Only
I
the
ignorant.
finding was a flamite.
Yes, it's the same from the cord map.
Okay. So, Karina.
Okay, first I want to congratulate you for the presentation because it was very, very, very nice. I think it was very high quality and it's amazing to see that you are doing such a great job in many other places. So really, I congratulate you. And some observations and questions. First, I think what is very important from the WB3 is regarding what Gustavo said, and I think regarding malformations of cortical development. There are some malformations that they look not nice in imaging, and they are quite frightening, and not necessarily the translation of the clinical prognosis is bad. So we need to be aware of this. That this is the importance to have the genetic confirmation whenever we can, and to have the multidisciplinary team. So to have the pediatric neurologist, the geneticist, the radiologist, and us, and the pathologist working together, because this will be the best way that we give the best prognostication and help these families. That we have the publication on the WB3, that it was very interesting case because the first child was already 9 and she was diagnosed like perinatal asphyxia and that she has cerebral palsy. This is first child. Then the fetus with the WB3 features was then terminated before we understood what it meant, because it looked like a severe or a diffuse brain compromise. And then when the third pregnancy came and we have the same pattern in the second fetus, then we said, okay, let's send the mother to MR. And then we invited the first child, and then we saw that everybody has the same pattern. The first child had a worse phenotype, and then she had these features that was all the time the square shape anterior horn was considered post ischemic changes of the brain, and they did not even do a genetic investigation, and she was mildly affected, let's say. And then after that we could understand the family tree and the prognosis. So these autosomal dominant abnormalities, sometimes they have different presentations, and we need to be aware that if imaging looks very bad, not necessarily that the clinical translation is bad, specifically speaking on tubulinopathy. So I think it's really very important that the patient have these comprehensive counseling on this type of a case. Regarding the cobblestone malformation, I'm happy that you brought it because we didn't have time to discuss it and to show the differential diagnosis with other types of smooth cortex. And I think it's it is indeed a case that our guess on the G is good, especially when we see the association of the Z-shaped brainstem and the other findings, and the importance on the counseling for these patients. Many times they have very early hydrocephalus. You send the patient to curettage, you don't do genetic investigation, and then they have a 25% risk of recurrence. So it's very important to send early hydrocephalus to investigate. And regarding the last case, my question is, did you consider to reclassify the filamine variant that you found? And together with the question, it comes a hint. We need to understand that the fetal phenotypes of the MCDs are not well established. And we need to help the HPO terms and to help the geneticists to establish the fetal phenotypes of the findings. So one thing that we do in our place a lot is to check on the variant, on deep in the specific variant, and sometimes then we send to the ClinVar and to other databases that this variant can present with a pathologic phenotype as well. And it helps the database of the geneticists to stratify better the abnormalities. So it's our task in the fetus to send and to feed these databases, because they are very poor with fetal phenotypes. So if you did consider to reclassify, and if not, maybe you should.
Thank you, Karina. That is a very difficult issue. Because that this MCD is not established completely, and now that we have the Professor Richard Reventhal. He just joined us. Would you please show up?
Ruchiko, can I comment something about how after the abortus, if you want to see the eyeball, say the blind 11L
Sorry, Prashant. Your the internet is a little bit unstable, and we cannot.
Okay.
What did you say?
If eyeball after the in abortus, use 11L ultrasound to evaluate the eye outcomes. That is the one of the system which we are using. If you
Prashant, the most probably, your internet is very unstable, and we cannot hear your voice. And hello, Richard. Thank you very much for joining us.
Hello, sorry I couldn't join the rest of the webinar.
Thank you very much. Your lecture was beautiful and wonderful. And yeah, actually, we learned a lot from you about especially the somatic mutation and others. And Gustavo, Karina, do you have any comments or the discussion with the Richard?
First, I am a fan, Richard. Sorry that I do it in public, but I really am. And I learned from you a lot, also from your publication and when you were here. And I remember you did as a quiz and showed us many postnatal patterns. And you make me envy the pediatric radiology every day, because you have myelin and you have the final phenotypes So we learned from you a lot, and thank you for your brilliant lectures. I have no specific question, but you just summarize how complex it can be and what are the newest advances. So we will keep on checking on your publications and the new things that you have to show us.
Thank you. I think I have a much easier job, as you mentioned, looking at a baby that's already been born that I can examine, and a scan that's the child is not moving, and as you mentioned, myelination taking place. So I think you guys have a much harder job than I do.
Gustavo.
Thank you for the lecture. Thank you mainly for being with us, to accept our invitation, because one of our goals is to bring people from other specialties, not only physicians, to the society. And you were invited to the Congress, but this time you were in vacations in Europe last year. And I hope you will come to our next Congress. It will be in January 2026. And what is important, we need to try to motivate you to help us with the diagnosis based on images that we have, because your understanding is much better than ours because of the experience with children. So thank you for being with us.
Thank you. I hope I can join you.
Actually, we have always, they're looking at the fetuses during pregnancy, the very early pregnancy till the late pregnancy. And sometimes, that we found the very rare, and it is questionable, that is abnormal or normal. And so I think, that we need the knowledge from genetics, and also, the pediatrics and the pediatric the imaging. So we learned a lot from you, and thank you very much. And here, Ravi Chawi from Germany. Ravi, do you have any comments?
I like very much your talk as the other, Rick. And while I was watching this, I was wondering whether you, in some selective cases, is there indication of doing brain biopsy, or one day we may ask people to do a fetal brain biopsy. Is it something where it is considered today or not yet? Because you cannot wait until there is a partial hemispherotomy and then to get this material. So is it something which could one day be available, especially when we know that for mTOR there are some treatment before starting with everolimus treatment, if there is anyone did it or thought of this?
Yeah, people have thought of things like brain biopsy. There's a few comments. So sometimes epilepsy surgery is done in 2 stages, where electrodes are put into the brain a week before the resection, and then they stimulate different areas and record from different areas. And now this is published, people have actually extracted DNA from those electrodes. I haven't actually used that yet in terms of guiding what sort of procedures done. But theoretically, you can actually do the genetic testing in that week between when the electrodes go in and you plan your surgery. That's not really a biopsy as such, but it is a way of getting DNA in advance of doing epilepsy surgery. Another thing people are looking at is making a diagnosis from CSF. So that's a little difficult, because at the moment you can't really do broad genetic testing from CSF, which is an exome. You need to know what mutation you're looking for, but there are, with mTOR, for example, there's 5 common pathogenic variants or mutations for the mTOR gene causing cortical dysplasia. And lastly, you mentioned mTOR inhibitors. Yeah, it'd be great if they worked, but they don't work terribly well for the epilepsy, and that's because they're not going to take away the malformation of the dysmorphic neurons. they might help a little bit with the epileptogenesis, so we still need better treatments. There was a paper a few months ago from the Bolat group in France about a very interesting treatment, non-surgical treatment, which they call a molecular scalpel, using things called senescent treatments. I think it was in Nature Neuroscience. It'd be worth looking at that. That's an exciting way potentially of dealing with dysmorphic neurons with a medication. I meant to say, I picked up on something that you said, Karina, that I strongly agree with. Cortical malformations can sometimes look terrible on a scan. When the baby's actually born and you know what type it is and what the gene is, you can be much more positive about the prognosis. We wrote a paper illustrating this a few years ago on Chudley-McCulloch syndrome as an example of a disorder that looks absolutely terrible when you see the MRI, and the children, apart from having deafness and mild or no developmental delays, actually do very, very well. That's an example of where the genetic diagnosis is so I joined you just as that presentation was ending. Sorry, I had other commitments today. I heard a lot of the discussion after that.
Em lên đây hình chưa hồi nãy nó mở cái phòng 7 số 8 rồi đó.
The scans can often look a lot worse than the outcome's going to be.
Ok. Là còn có hai chị em mình thôi đúng không?
Thank you very much. Maybe if we can do the CSF examination from the cortical malformation cases, maybe we can extend something, in the fetal field. But maybe because of the small amount of the DNA or the small amount of the cells containing the mosaicism or something, then maybe it is difficult.
Yeah, I think I mentioned that in my talk, that it's very difficult to find these very low-level mosaic cases. You need the right tissue. You might even need the right cells within the tissue in the case of dysmorphic neurons. And then you need to do very deep sequencing techniques. There must be, none of that is available in clinical labs. It's all in the research realm at the moment.
Thank you very much. Karina?
I found a question in the end. Rika, do you perform any other laboratorial assessment in patients with polymicrogyria whenever you rule out a genetic cause? Because, I see many of the pediatric neurologists, sometimes they treat the child and the family does not receive the proper counseling regarding risk of recurrence. As well, in pregnancy, we are always thinking about the chances that things will recur, and we need to advise for further pregnancies. So we try to. I have like my clinic where I do the puzzle settle. When I take all the aspects and I try to recommend what to do regarding further pregnancies. And in cases of PMG, because we know that many times it's not genetic, and if we rule CMV or other things, we get a little stuck. So I wanted to know if you do any other investigation in order to understand why did it happen.
We also get a little stuck. I don't think it's unique to fetal, because PMG, despite being so common, we understand so little about it. So the standard thing is we get out the Guthrie card and do CMV PCR, and we do an array looking particularly at 22q and 1p36. There are other deletions associated with PMG. And then ideally you do a trio exome, but beyond that, not much more we can do for PMG, and with all that, chances of making a diagnosis are no better than about 30%.
Thank you very much for the discussion. And so we will move on to the next educational lectures. The Professor Dr. Daniela Prayer was head of the Research Institution Division of the Neuroradiology and Musculoskeletal Radiology at the Department of the Biological Imaging and Image-Guided Therapy at the Medical University, Vienna. And she has a lot of experience with the fetal brain MRI. So the Professor Daniela Prayer, please start your lecture.
Thank you, Mitsuko, for inviting me to talk about MRI imaging of fetal MCD. Recently, a new classification has been published to classify prenatal MCDs as they appear on MRI images. And as you can see, what has to be taken into account here is laterality of the lesion, whether it's bilateral or unilateral, symmetry, whether it's asymmetric or symmetric, and then a classification was done with the morphological description. It was seen that MCDs are more frequent in male fetuses, more frequent when the brain is small, and more than 50% of the disorders were associated with problems of commiseration. The problem is we still do not know what features can you see in the second trimester and which ones in the third trimester. And is it really true that a reliable diagnosis of lissencephaly is not possible before gestation week 27? Well, what can be the underlying background of an MCD? There are, of course, genetic mutations. They can cause impairment of cell proliferation, migration, and post-migrational maturation, leading to all these pictures we know from images like in pregnancy, ultrasound or MRI, or postnatal images. But exactly the same changes may be a consequence of infection, of toxic events, or vascular events. So, what we want to know is the background of such a malformation a genetic one? Well, mutations in one gene may cause different malformations, and mutations in two or more different genes may cause one and the same malformation. So what we want to know is there a genetic background, or is there a background of an acquired malformation? And we have some morphological signs that may point towards an acquired background. These signs are hemorrhagic residuals, twin pregnancy, or additional other signs outside of the brain of fetal placental malperfusion. Maybe there is a history of an environmental insult, such as, for instance, an infection, or schistocephaly, which may more often be acquired than has a genetic background. Why do we have to make this differentiation prenatally if possible? Because postnatally, neuroimaging may less be able to distinguish genetic from non-genetic causes. Let's start with the hemorrhagic residuals. Here you have two different cases. First one is week 30 of a 14-year-old mother, and you can see on the diffusion the residuals of an ischemic infarction still bright on the diffusion-weighted images. You see hemorrhagic residuals here indicated by the yellow arrows. The second case, week 31, a 16-year-old mother shows bilateral infarctions. Well, you might call that hydranencephaly. And if it is survived, it might end up as either porencephalic defects or, if lined by gray matter, schizencephalic clefts. The next risk is twin pregnancy, because we know there is a huge percentage of defective vasculogenesis, thrombosis, and emboli. Very often we see polymicrogyria bilaterally or unilaterally, but also subcortical heterotopia and periventricular heterotopia. In this study, 61% of acquired brain pathology was MCD. The others were, as you see, cerebellar hypoplasia or other brain disruptions. Let me show you an example. This was a twin pregnancy where both twins had polymicrogyria. As you see, twin fetus 1 on the left side of the brain and fetus 2 on the right side of the brain. And if we look at the placenta, in this so-called echoplanar sequence, you see huge venous congestion, but in one twin, with the blue arrow on the right side of the image, you see there is also venous congestion of the penetrating vessels on the side of the hemisphere where the polymicrogyria was seen. Let's look at another case. Is this a focal cortical dysplasia? It looks like that. We saw this child at 4 years where it has a circumscribed region of pathological gyration, and with 2 years there were still the remnants of a schizencephalic cleft. But how did it begin? Well, it began in gestation week 23, 2 weeks after umbilical cord occlusion because of TTTS, and this is to survival between, showing a region of impairment of cortical maturation, very circumscribed region. And if you look at the same fetus at gestation week 29 and 32, then you see there is polymicrogyria. And if we want to go back to the same child, as I already showed you, with 4 years, it was not anymore recognizable that this was a schizencephalic cleft and a rather big region of polymicrogyria. What we know in the meantime is that schizencephalic clefts change their appearance not only prenatally, as you can see in the row above, but also postnatally. So if you image a child later on, a small region of something that you might interpret as focal cortical dysplasia may appear that originally was a large region of polymicrogyria and in most cases schizencephaly. As I already said, other manifestations of vascular disruption may be present in other regions of the body. In this case, schizencephalic clefts were combined with bowel atresia and microcolon, and the orange arrows point also towards placental hemorrhage. So the schizencephalic, if you see that, you know the schizencephalic clefts are most probably of vascular origin. And then there is, of course, something that we always consider and do tests. It is MCD as a consequence of infection, most frequently of CMV, and during the Zika time, we also had very often Zika as a reason for focal or for cortical dysplasia. The reason is that CMV and also Zika impairs the microvascular endothelium, and so this is also more or less a vascular origin of an MCD. And here we have an example of CMV where you see a combination of subependymal heterotopia with bilateral polymicrogyria, and of course there are also other signs such as pseudocysts of this CMV infection. The next case, in gestational 25, you see a huge malformation of the cortex with a thin and calcified parenchyma pointing towards laminar necrosis. If you see cases like that, and you don't find the infection underlying region, it may be a mimic of an infection-based MCD. And here, for instance, we see an example of an icardic Gutierrez syndrome. This is a fetus in gestation week 24, where it is not yet obvious where the extent of this cortical malformation is not yet obvious, but when we look at this fetus in gestation 33, then you see that the cortex is destructed and the non-destructed regions are polymicrogyric. Of course, there is also a widening of the ventricles and cerebellar impairment and calcification. Why you should think of icardic Gutierrez or other so-called interferonopathies is that there is a therapy available, because anti-interferon antibodies may stop this development. And that's why it is worth to think about that. But let's move now to the morphological signs that may point to a genetical background. There may be rather strong signs, such as gradients, premature gyri or dysgyria, persistence of transient structures, or other signs of a genetically determined syndrome, and of course similar findings in relatives. Weaker signs are the presence of a dysplastic or hypoplastic brainstem, the shape of the brain, and symmetry or asymmetry, it depends. When we talk about gradients, then we talk about occipital predominant or frontal predominant shapes. As you can see, either the posterior brain is lysencephalic and in the front you have some gyri, or it is the other way around. Unfortunately, it has been found that radiological findings could only reliably predict the molecular results with a posterior to anterior gradient, as you see in this example on the right side. The other gradients only point towards a possible genetic background, but you still have to consider a lot of genes that may be there with this gradient, and here you have another example. A better sign are the premature abnormal gyri. If you see already gyration at an age where no gyration should be present, as you see on the left side, gestation week 22, gestation week 25, and in the middle there is the outcome. It is a muscle-eye brain disease with polymicrogyria and, of course, with a very pathological brainstem that could be seen already in earlier stages. On the right side, you have an example of an unpaired, where you have already strange gyri in gestation week 24, and in gestation week 30, you have polymicrogyria, and of course, if you look more closely, I will talk about that a bit later, you have persistent ganglionic eminences that should be not there in that size in gestation week 30. When you have premature abnormal gyri, that you think of FGF mutation, you can have even gyri in the temporal and posterior regions at gestation week 17 or even earlier, and this allows to recognize these FGF mutations at a very early stage when you might not have other signs of these diseases. Dysgyria, what does it mean? It means strange gyri or an abnormal pattern not fitting in a category. Also, there can be an abnormal arrangement of gyri and sulci. Here you have very subtle signs of a sagittalization of the collateral sulcus, and this may also be a sign of FGF3 mutations, especially as in this case in chondral dysplasia, where all the other signs of abnormal cortical folding may be absent. But let's now move towards the persistence of transient structures. Here you see a persistence of the germinal matrix in the upper row of the fetuses. In the lower row, you have normal fetuses of the same age. And here another example where we can really see in the lower row this very big germinal matrices that are in an otherwise mesencephalic brain. Then you can have also lesions in the germinal matrix, in the ganglionic eminences, and there are three beautiful papers from Regini where you can see the ganglionic eminence anomalies, but they also later are associated with specific neurodevelopmental anomalies. And here we see an example of cavitation in a case of a metabolic disease, in this case pyruvate dehydrogenase deficiency. And another example would be this. We perform 3D volumetry of the ganglionic eminences and have normal values. And you can see in the lower row, these ganglionic eminences are too small because this is a gene mutation associated with mitochondriopathy. What about the dysplastic brainstem? The dysplastic brainstem is always a really strong sign that something is going wrong, and you can see it in the upper row compared with the normal fetuses in the lower row, and it is a persistence of the embryonic shape of the brainstem. And a flat pons that is not really dysplastic but also flat is usually a sign of the presence of a tubulinopathy. What about symmetry? Well, symmetry may be present as in mesencephaly 1, in cobblestone cortex, in X-lag mesencephaly, but it is absent in icardi. Well, icardi, you will say we don't know whether there is a genetic background, but if the presence of one is strongly suspected, and of course also in hemimegalencephaly, where we know there is a genetic background, these morphological changes are asymmetrical. Let's move to the brain shape. Some years ago, we found that this flat brain that we call toast brain, where the insular indentation is too flat and the temporal lobes are wider than the frontal lobes, may be a strong sign of a genetically determined malformation of cortical development, and of course, this has already been described in literature. Other signs of a genetically determined syndrome, what we see here is, in addition to an abnormal cortex, you have the pathological brainstem and the delineation of the internal capsule that you see perfectly in the case in the blue frame is missing in this example of type 2 tubulinopathy. Here is another example. We have a mesencephaly with the gradient. The frontal cortex is smooth, the posterior cortex not. The corpus callosum is missing, and there is pontocerebellar hypoplasia. And of course, we thought of type 2 tubulinopathy, but this was not the case. We needed another pregnancy to make the diagnosis. This was VT syndrome, a syndrome that is also associated with extracerebral anomalies and with some anomalies that only can be seen postnatally. And here, this would also be an example of similar finding in relatives as the first fetus had already the signs we see in this second pregnancy. But maybe a better example of similar findings in relatives is, of course, the filamin gene mutation leading to subependymal heterotopia, sometimes associated with megacisterna magna, sometimes not. And as you can see here, the megacisterna was pregnant in both fetuses, but not in the mother. And MRI allows you to examine the mother right after the fetus, and that really sometimes help with your diagnosis of a genetic mutation that is also present in the fetus. So, MR imaging of fetal MCD, there are morphological signs that may allow you to differentiate between acquired and genetical etiology. However, in case of hemorrhage, you also have to think of a genetic background, but a different one than usually in MCDs. You have to think about collagen gene abnormalities. And as I could show, I hope so, prenatal imaging is important to identify the original morphology of an MCD, as it may change later and look completely different than prenatally. Thank you very much for your kind attention.
Thank you very much. And the last one is my talk. And because of the time, I reduce many of the slides. So, I will present only the 2 minutes. I will try. And so can you see my slides? My talk is about how to diagnose political disorders in mid-gestation, and actually, the Gustavo and Tari proposed the 10 points in a practical prenatal approach to MCD, including MRI, transvaginal and transabdominal neurosomnography. Of course, MRI is a strong modality, but we need to make diagnosis or have suspicion of MCD during our routine clinical practice. But it is quite difficult.
Alo, anh rảnh không, nói chuyện được không?
Gestation, the brain is very, very smooth. Brain surface is smooth and no gelification.
Em hỏi cái vụ không, em đang bạn em nó mở phòng khám nha, xong nó muốn đặt máy siêu âm á, em hỏi anh vụ mua hay thuê với lại xét giá sao em không có biết, chỉ với em.
However, sometimes the ventriculomegaly is not often showing up. It is very mild or absent in MCD cases. And also, already Gustavo told about the macrocephaly and microcephaly, and brain size is very, very important. And also abnormal gyri outside. This is only the very abnormal gyrification in this picture, the ultrasound and MRI. And sometimes, here, this is abnormal RE gyrification at 20 weeks of gestation. This is a P10, the variant of the paternal UPD. Now, lateral ventricular irregularity, sometimes those are 3 cases of the irregular ventricular wall, 24 weeks, 19 weeks, and 20 weeks of gestation. You can see this is exactly the periventricular heterotopia. And sometimes, that we see that this kind of the irregularity of the ventricular wall. And here, this is a question, is this just the lateral
Thì là
ventricular
ngoài giờ đó,
asymmetry?
em chắc là ngoài giờ
And
thôi,
here
tại
you can
vì
see
em đi
18
vướng bên
weeks
trung
and
tâm
20
anh
and
đâu có được
23
đăng ký
weeks of
full đâu.
gestation. You can see the very, the asymmetrical structure of the anterior bone. Where something here is I concerned. Here, this is 18+6, and you can see this is the width of the lateral ventricular wall. And then after that, 20 weeks and 20+6, you can see this is much sharper, the week by week. And then after that, 23 weeks, the very sharp, but thereafter 25 and 27
Còn cái
weeks
vụ
of
xét giá
gestation
làm sao anh? Em không có rành á. Anh nên mua máy lại mượn máy nên mua hay là nên mướn rồi giá làm sao anh?
So the time delivery with a favorable